1, 2. Morning, everyone. I think we're going to make a start. Thank you for joining us this morning. There probably will be one or two people coming in dribs and drabs, but we will get going. I'm Sarah Woolnough. I'm the Chief Executive here at the King's Fund. And today we are meeting to discuss 100 days of the new government. It's actually day 110, but there's lots to discuss. A couple of housekeeping announcements. No fire alarm planned, so if it goes off, it's the real thing. We are live streaming the event, and for those who can't attend or want to watch it back or whatever, it will be available on our YouTube channel later. If you want to tweet about it or post about it, it's hashtag KF100days. Okay, well, I'm really delighted. We've got a fantastic panel this morning, and we're going to hear from each panellist for around 5 minutes. We're then going to have a bit of a discussion on the panel before opening up and taking as many questions as we can. Hard finish at 9:45. And so to briefly set the scene, our new government has had an unenviable entree, I think it's fair to say, post-election. We have seen, as we published, the King's Fund with the Nuffield Trust earlier in the year, the lowest ever levels of public satisfaction with the NHS recorded since we have been measuring. We've got industrial action, some of which has been resolved but some hasn't, a fractured workforce, a tough financial climate, and really tough decisions that are going to need to be made in the first budget. And pretty severe winter pressures, although are they just winter pressures, or in reality are they kind of all-round pressures? We've got many millions on waiting lists, a huge capital backlog, constitutional standards that haven't been met for many years, and of course behind these constitutional standards, things like cancer wait times, an elective backlog, urgent and emergency waits. It's real people waiting a long time to start their cancer treatment, or an awfully long time in A&E as an example. From a public health perspective, we know that public health grants and settlements in local authorities have been frozen. We have a social care system that isn't really fit for purpose. All of this culminated in our new Secretary of State defining the NHS as broken, and that being the policy of the Department of Health and Social Care. So in that context, that really unenviable entree that the new government faces, what's happened thus far? What are we looking for from the government as we move forward? How can we, I think, critically think about the short term, the urgent, the emergency, or how does the government think about this, and putting out some of the fires that are currently burning, with thinking about some of the longer term shifts that the government has talked about, and which others on the panel may allude to, so I won't go into in detail. And perhaps that's the key tension, the short term versus the long term. There are other tensions, no doubt. So on the panel we have our Acting Director of Policy, Siva Anandaciva, who's going to present, Dr. Anna Dixon, new MP for Shipley, done lots of things in the past, including worked at the King's Fund for a period of time. Welcome. Dame Una O'Brien, former Permanent Secretary at the Department of Health, and Rachel Wolfe, who's also done lots of things, but is the founding partner at Public First. So we're going to take it in turns to hear from our panellists. Siva, you're up first.
Thanks, Sarah. Hi, everyone. So part of my job is to set up the discussion for the rest of the panel, and I've got slides to do it. If you're watching the live stream, you should have access to the slides, but I'll describe them as I'm going along, and they'll be emailed out afterwards. The first one's going to be pretty easy to describe, because it just says, when you look 100 days in, a lot's happened, there's a lot going on, and there's a lot still to come. More profound insights to come from the panel. But I'm going to throw a lot at you, so I wanted you to have something quite simple to hold on to, because a lot has happened. Let's do a quick timeline. So even before the election, you get, as you would expect during an election, a manifesto. Read the manifesto, but also read the mission document, partly for what it says about the government's plans for the health and social care sector, but also for a new way of doing government. If they pull it off, I think a mission-led government, where you look at what other government departments can contribute to the health of the nation, will be one of the distinguishing features for this government. And we'll come back to mission-led government, I'm sure, later. As Sarah said, the election happens, Secretary of State walks into his new office and says, "It is the policy of this department that the NHS is broken." I was with a group of clinicians on Friday, and I swear to you, you could see and feel the division in the room. I had one clinician who said, "Do you know what, for the first time, I felt seen by a national politician. Someone wasn't glossing over what it is like to do my job." So he is absolutely right. I had another clinician who said, "I've stopped listening to a word that man says. He lost me the minute he said that my service, the service I provide, I'm working my bloody socks off in, is broken." So the one thing I can say for sure is when you use language like this, for whatever purpose, it raises the stakes. And we'll come back to that later on. New advisors are brought in, including my old boss, Sally Warren. New advisors, but familiar faces. Every single person on this list is someone who was working in or near the Department of Health when I started my career 20 years ago. So that's another thing we can come back to. The King's Speech. I think both the previous government and this current government deserve credit for pursuing the smoke-free generation legislation. We'll talk a lot about policy and politics over the next hour. I think when I look back over my career, this will probably be the single biggest thing that makes a difference to the health of the nation. Hopefully, more to come. Then some bad news. The Chancellor looks at the books, finds there's a fiscal black hole, and things that we're committed to, including the new hostels programme and charging reform of adult social care, are paused. And I'd just say normally this is the sort of thing that we'd go absolutely bananas about. But the noise in the system seems remarkably low at the moment. But both of these two big ticket items have been paused. And then September comes along and you get some further appointments in the health and social care superstructure. Tom Reardon's an interesting one, former leader of Leeds City Council. Someone described him to me as the second most important appointee to the Department of Health and Social Care after the Secretary of State, partly because he's bringing a different culture and approach. If you look at NHS national policy documents, words like neighbourhood and place have a very specific meaning. To somebody like Tom, a neighbourhood is a collection of streets. It's where people live. So that's part of the change I think he is bringing. Lord Darcy's report comes out on the 12th of September. Read it. It's a really good and interesting piece of work. And I would say it's almost perfectly designed as a mechanism for something. You get an independent, eminent clinician to come in and say, "Good Lord, what we've inherited as a government is even worse than we thought. Do you remember all those commitments we made about getting access times back within the course of a parliament? It's going to take longer than we thought." Perfectly designed mechanism to do that, except for the fact that on that morning news round, and subsequently, the Secretary of State has said we are going hell for leather on recovering waiting times. So again, this is a conundrum. How can you inherit this mess and still, on this time frame, deliver everything you're saying? But the other thing is, from this point on, the language starts to moderate. An opposition politician said to me that the NHS is broken is the language of a campaign, the language of opposition. The NHS is broken but not beaten is more the language of a government. Labour Party conference, and I mentioned the health mission. This is where you start to see, again, a subtle repositioning of health and care policy, where the health service is offering up gifts to the government's overall growth mission and trying to see how the health service can do more to get people out of work or economically underactive back into employment. And then a bit more technocracy. You get the mission board chaired by the Secretary of State for Health and Social Care, not the Prime Minister. And it'd be good to come back to that because that's a big choice, that's a big call. You get the penny dash and Sir Mike Richards' review of the CQC, and you get Richard Meddings announcing that he's leaving office, and I anticipate we'll talk a little bit about NHS England, Department of Health and Social Care relationships. And then yesterday, is it yesterday? What day is it today? It was yesterday, yeah. Yesterday we got the listening plan launched for the 10-year plan, 10-year health plan, and that sets us on the course for the future. So we've got the autumn budget in the near term. We've got the Conservative Party leader announced we don't know that much about the detail of their health and care policies, but you know what? I'm pretty confident they won't be boring. We've also got the NHS planning guidance, which is a usual part of annual planning. But really it feels like we're waiting. We're waiting for something. And what we're waiting for is the 10-year health plan, which the government is aiming to publish around May, closely followed by the comprehensive spending review. that sets budgets for the rest of this Parliament. And that should be it. That should be an intense sprint to develop an awful lot of national policy and set the course for the rest of the Parliament. So a lot has happened. And I said a lot is going on. You've got the health mission, that's part of the 5 missions. It has 3 pillars. The first being an NHS there when people need it. For that, think of your access targets, waiting times for cancer, hips and knees, A&E, mental health treatment, ambulances. Fewer lives lost to the biggest killers, including cardiovascular disease, stroke, suicide and cancer, and survival rates from that. A fairer Britain where everyone lives well for longer, healthy life expectancy growing for the population as a whole, and reducing the gap between the richest and poorest areas. So 3 pillars supporting the health mission. And a lot of this focused around primary prevention of disease, so tackling underlying risk factors like smoking, air pollution. So 3 pillars, but keep them distinct from the 3 shifts, that you've probably heard about ad nauseum: treatment to prevention, analog to digital, hospital to community. That is the focus of this 10-year health plan that is being developed in time for May. So 5 missions, 3 pillars, 3 shifts, 3 task forces, about 16 to 17 manifesto commitments. This is a lot, right? This is a lot. And this, by the way, is the most modern thing I've done. I was going to do a magnifying glass, but it's actually one of those, I don't know what you'd call it, but things. A dentistry rescue plan, a national care service, and recovering all constitutional standards would be a Herculean achievement for any government over the course of a Parliament. These are 3 bullets on an incredibly busy slide. There is a hell of a lot of ambition in what the government is trying to pull off over the course of one Parliament, even if some of these are potentially 2 Parliament commitments. So the final thing is, I said there's a lot still to come. Here are some of the priorities of the last 5 Secretaries of State for Health and Social Care, depending on how you count Steve Barclay. We've had 4 Ps, we've had 2 Bs, we've had A, B, C, D. None of these politicians turns up wanting to do a bad job, and none of the officials who support them turn up wanting to do a bad job. Everyone turns up to work wanting to do their best for the health and care service. But when your tenure and when your churn of Secretaries of State of Health and Social Care is this wild, where you've got people who aren't even making it to 100 days, what that can create, that instability, is inertia. And strangely, not a lot of change in the policy environment. And that's certainly what I've experienced over the last few years. I would say, buckle up, because this Secretary of State does plan to be in post for 5 years and will use that stability, coupled with reformist zeal, to really fundamentally try and change the health service and make some of the prioritizations and trade-offs that I think we've really ducked over the last 15 to 20 years. So I guess my final point is partly buckle up, but also take care of yourselves. Because to people like me, reform can sometimes feel exciting and interesting and good to study. For those clinicians, when I was talking, some of them were seeing this as a threat. Some of them were sat there thinking, this all sounds great, but am I going to have a job at the end of this process, and what will it look like? And that's a hell of a lot for people like you to hold and manage as you're dealing with this reform agenda. So public health announcements, buckle up and take care of yourself. And I think over to the rest of the panel.
Siva, thank you. A brilliant kind of summary and canter through lots of what's been announced. Anna, a newly elected MP, background in health and social care, really interesting perspective on what people are talking about on the ground, as well as an insight into new government. It'd be fantastic to hear your reflections.
Thank you, Sarah, and thank you, Siva. No wonder I feel exhausted. I mean, just hearing you go through everything that we've been living through as new MPs over the last 100 days. I was a candidate actually for 2 years before the general election, and during that time, obviously, I was out speaking to people in my community, which is within the Bradford district up in West Yorkshire. If people can't like to locate Shipley, maybe not somewhere you've heard of. And these issues that are in the national data that the King's Fund and others produce around low public satisfaction, high waiting times, that's reflected in the conversations that I've been having, you know, people's frustrations about not getting in to see the GP, particularly in some of our poorer communities. So there's a real, you know, you see that inverse care law even within my constituency, with some good practices that are managing to deliver access but others really struggling. NHS dentistry, total lack of it. People even not getting their children to be able to be seen by the dentist. One older woman I saw, you know, struggling to eat in pain and had been sort of ditched off the list by the local dental practice had traditionally had NHS access. So these things show up. They show up with people who are waiting a very long time for an operation and having to have given up work. So, you know, those are the real stories that I get. So, you know, I think that's one of the great things about being an MP. You know, I've spent my life looking at the numbers and the data, but it's where it really bites on people's lives and impacting. And I think that's, you know, what's so fantastic about the Labour government, the mission-led approach, the ambition that we have, is seeing that getting people healthy and getting them social care. So, you know, the other thing I find are people behind closed doors who are really struggling to manage caring for a disabled or older loved one, maybe trying to still work to pay the bills, and absolutely having to fight for any access to care and support. So, you know, all of these things are a drag on our economy. We know that people are out of work due to ill health. We know that you know, people are dropping out of the labour market to care. And that's why this mission-led approach is recognising that we won't, as a government, deliver on economic growth or our other ambitions without, you know, fixing, to use the language of broken, you know, but not beaten, to really restore and revitalise the NHS, but also this huge ambition over 10 years to build a national care service. And I think, you know, you rightly highlighted that is not a small thing. And as somebody who's sort of spent recent years thinking about the future of care and support in this country, and also, you know, having worked on health and social care and seen the failure to reform over many decades, it feels to me that if, you know, and it is a 10-year horizon, we can, you know, once and for all make that very fundamental reform on social care. Those things will impact real lives of the people that I represent in my constituency. So, you know, but just in terms of the first 100 days, you know, it has been amazing to see, you know, the pace at which the new team, well, you know, they've been in there in shadow form, and I think that's been really helpful. They did loads of preparation for government. So they've hit the ground running, as you can see, in terms of, you know, ending the junior doctors' strike, passed into legislation yesterday the Employment Rights Bill, and somewhere in there is the Fair Pay Agreement for social care workers, the 1,000 more GPs. So when I took Wes during the election campaign to one of my local surgeries, they were saying, we've got a trainee GP here. They're ready to go. We want to employ them, but the rules around the funding are stopping us actually. And he listened. And that's been changed, and those trainee GPs coming now out of trainee programmes can go straight into jobs in those practices. So there's a lot happening, and as you say, a lot more to come, whether it's the tobacco and vaping bill, the ban on some of the junk food advertising around children's health, the ambitions about digital passport. You know, I'm not naive about delivery on these things, having been around health and care for many years. And seen numerous attempts to fully join up and digitise. But, you know, we're absolutely serious about that switch from analogue to digital. And goodness me, isn't it overdue to deliver on that? And then, of course, the national conversation. So we know we haven't got all the answers. And so launching this national conversation. So the clinicians, you know, that Siva, you were talking to, and patients and the public, will be able to come forward with ideas. You know, they often know what are the things that need fixing, and I think that's how we say reform isn't something that's going to be done to you. We are listening, and this is about making changes, you know, not some big restructuring again. You know, we had enough of that with the Lansley bill, didn't we? So this is about trying to fix almost the small things, in places, in neighbourhoods, and building care around people. But we can probably come back to more of that in conversation, Sarah. So those are just a few opening reflections. Thank you.
Thank you very much, Anna. Una, you've got a hell of a lot of experience of being right at the heart of government when a government comes in wanting to reform, wanting to sort of overhaul elements of health and care. You spoke at our annual conference, and actually you said something which I've been pondering ever since. You might say it again this morning, so I won't potentially steal your thunder, but really great to have you here, and would be fantastic to have your perspective.
Yeah, thanks very much, Sarah, and great that you're putting on this event this morning. I was pondering what to say, but having heard Siva's fantastic account of all the facts that have happened, I'll step back from the chronology, and I just really want to connect with what Anna's just said, because my sister is currently been over a year waiting for a knee operation, and went for that operation on Tuesday. Sat in the waiting room for about half an hour, wasn't called, only for the nurse to come out and say, well, you're not actually on the list. And she's holding a letter saying your operation is this morning. So for all the big stuff about reform that we're going to talk about, this touches all of us in our families, and the sort of day-to-day dysfunction is really placing a toll on people, which is not possible to measure. And I just wanted to mention that because all these small things and small interactions on a daily basis are what is adding up to the sort of frustrations, I think, Anna, that you're encountering. And so now it's been very interesting for me, after 30 or more years in health policy, to spend 8 years, a regular citizen, encountering the health and care system where I live and through my family and friends, and learning different things about it from that experience. But let me just go back for a moment to what I would call the playbook for an incoming government, and cheekily, perhaps a little bit of a scorecard for the team. They have done incredibly well, and I think a large amount of that was down to the preparation. It's said that they were the best prepared of the teams going in. I don't know whether that's true, whether anyone's evaluated it, but I've certainly heard that from several different quarters. And they did a lot of detailed work and detailed planning. Let's just look and try and group some of the chronology that Siva talked about. Reset. Definitely big tick on that, a strong and striking reset on the narrative. Perhaps sort of slightly overstated. I like the more moderated, broken but not beaten, because it's really, really important to give everybody a sense of hope and possibility. The changes we're talking about will only come about if everybody plays their part, and therefore you've got to believe that you have a part to play. I like the reset, such as it is, around public health, the smoke-free legislation, but I'm worried that we're going to get stuck in sort of the smoking alcohol world rather than the wider public health world, which is really where the change is needed. And on social care, well, we haven't seen very much. I mean, the Fair Pay Agreement is going to be good when it's implemented, but there's still a bit of an empty space there. So on reset, I'd say pretty good so far. Review, the tool of the review is very much part of the playbook for an incoming government, and you have to say that's been used to great effect. I mean, I would call Lord Darcy's review emphatic and strongly evidenced, and what a fantastic team worked with him on producing that, and it will stand the test of time. Safety and quality, we haven't touched on yet the work that Penny Dash has been doing, but I'm very encouraged by the way in which the new government has sort of seized that and now widened her remit to look at all the national organisations. Perhaps it's an overcrowded landscape now. Too many bodies have been created to look at different aspects of safety and quality, so that's a good one. And the red tape review in primary care, great. Pressing the brake pedal on capital had to be done. We're not quite sure what's happened to the proposal on mental health. I think we were expecting to see that legislation quite quickly, but maybe for reasons of some very serious, those terrible murders in Nottingham, there's been a bit of a rethink about how to position the mental health legislation. I don't know, perhaps some of our audience here today can bring us up to speed on that. There have been some very effective interventions, teams of specialists going into certain parts of the country to help with the waiting lists. Not many people would see these, but they are there on the NHS England website, ministerial letters out to local authorities and to the NHS, giving early signals of the priorities, particularly around collaboration. And also, the one I'm looking out for will be the operating framework for 25-26, which we would expect to see December or January. And that will give a very clear signal of expectations around performance, certainly for next year. I'm excited by the whole change initiative launched yesterday, but we're talking at the start this morning, what is the model of change that is going to support that? All the evidence on strategy from the commercial sector, from the public sector, is that source of failure is 25% policy, 75% implementation. So while we all get swept up in the whole policy and ideas dimension, are enough people thinking about the model of change and how the shifts are actually going to be implemented? And for my money, I really want to see much greater devolution of power. I do not think you can orchestrate this level and complexity of change by pulling more power into the centre. Certainly not a country the size of England with 70 million people. So that will be my big test when we see the NHS plan, not only, of course, the resources that go with it, but the model of change and where responsibility and accountability will lie to make the difference we all want to see.
Thank you, fantastic. And finally, Rachel, so you have written a former Conservative manifesto. You've done lots of public polling to understand where kind of people are. You've written a paper on NHS productivity. And much more. Your reflections.
What do you want me to talk about? So I thought, given what everyone else has said and the sort of tour de force that Siva gave at the beginning, that what might be most helpful is if I just talk a bit about the political context within which health decisions sit. So echoing a little bit what others have said, health in the NHS was one of the major drivers of anger and dissatisfaction with the last government. It has consistently polled either first or more often second against cost of living as the major issues for people in the country. And when you did focus groups before the election, and it is still true, not only were the kind of common drivers of health satisfaction, which is often GP appointments, high, but there was this very reasonable fear from people that if they or a relative were on the floor, the ambulance might not come and they might die before they even get to A&E. So there is no question that the public think that the NHS is in crisis. And one of the things that I think is interesting, it hasn't come up today, but also never comes up in focus groups, is no one ever mentions COVID. It is as if it never happened. And therefore, in their minds, and maybe you think this is a failure of government communication or it's just a natural feature of human psychology, in their mind, the challenges of the NHS today are somewhat divorced from what is one of the major causes of the challenges of the NHS today, which is what happened in COVID. However, I think it is worth also reflecting three things that I think make decisions on health very challenging in a sort of broader way. The first is, I was just checking the YouGov data, since the election, there has been a flip, partly because of the budget speculation. In July or June, just before the election, more people would have said that you need to spend more on public services and that we're taxing too little. So more people would have said tax more and spend more on public services. That has completely reversed since the election. So on the latest YouGov data, 36% will say we tax too much and spend too much on services, versus 25% who say we tax too little and spend too little. So the public as a whole are not going into this budget, which we haven't really talked about, thinking that taxes should go up a lot because we need lots more spending in public services. And that's almost certainly because they've been hearing a lot about taxes and now they're really thinking about it and they've decided they don't like it that much after all. We've also in the last year or two, had this growing split. It's actually not reflected in today's YouGov data, but it is a growing split between working age people and younger people who, perhaps because they use it less, see the NHS as much less of a priority, versus older people who pay fewer taxes, who see it as much more of a priority versus the economy. So that is a really big change. I think the second of my three things that is worth bearing in mind is that we are in an era of pretty unprecedented political cynicism and distrust. And those levels are very, very high on any given measure. And one of the fascinating things, as you will all know, about the election is we have an unprecedentedly large landslide based on a huge number of marginal seats, and where there is now for the first time a split almost four ways between four political parties. We have a sort of non-first past the post system, and therefore there's a lot of inherent volatility and anger in the public, and a lot of people who don't actually feel that the size of the government and the mandate of the government is reflected in their vote. And they are simultaneously, and this is my third point, I think most people in this room would argue unrealistically, but they are, of the view that things can change quite fast, that it's not really that hard. So one thing that we polled around the election was how soon, first of all, do you expect the government, the next government, to improve the NHS, crime, economy, and how fast do you expect them to do it? So on the first, actually, people were more optimistic about the NHS than almost anything else. They were much more likely to say that the next government, Starmer's government, would improve the NHS, GPs, A&E waiting times than, say, crime. And Labour voters were really quite optimistic. About 60 to 70% of them versus about 40% of the overall public thought that the NHS would improve. And they also thought that it could improve really fast. So about almost half of those people thought that services were going to improve within a year. And what really strikes me, maybe that's true, but what really strikes me about Siva's list is that on the one level, as Una said, they've done so much. They've announced a bunch of changes, they've done a review, they've really looked at what they want to do, they've announced this really exciting thing around digital ID or whatever we now are allowed to call it yesterday. And on the other hand, they haven't done anything. Right? And that's perfectly reasonable because it takes a long time to figure out what you want to do with the NHS when you come through. But the expectation of the public versus the reality of how fast it takes to change this system are completely out of whack. The final thing that I will say is that we inevitably, and this is true of every public policy area, tend to focus on the very difficult fiscal environment and the huge pressures within our world, which is the NHS, and it's a big world. But pressures that exist here, from the point of view of lots of other cabinet ministers, the public and services, my God, do they exist everywhere else? And it is likely that there is going to be both a tight and a relatively good settlement for the NHS in the next year, because there always is, and everything else is going to continue to fall apart. We don't know what Rachel Reeves is going to do on investment. That might make a difference. It will take a while to come through. But they are going to heap the pain now on taxes so that they don't have to do it again in 2 years or 3 years. They're going to try and do the settlement now on the NHS so they have the biggest possible chance of delivery, which makes sense in investment. And that means that unless growth really starts to pick up and we can have that conversation, it's going to be hard for it to keep coming. So I think that they are facing a really difficult job.
Thank you.
I'm still smiling.
I'm going to come out to the room in about 10 minutes, so do have a think of questions you'd like to ask the panel. But first, I want to pick up on a couple of sort of threads and points that have been made, both about public expectation of things shifting quickly, and something, Una, that you said at our annual conference about time, which is, governments will get blown around by events. They need to frame ambitions and set a course of direction pretty clearly, pretty early on, to try to safeguard against that. And so the question is really this sort of short-term, longer-term. How does the government, with a huge to-do list, keep one eye on the longer term and the shifts that I think at Labour conference I went to bed dreaming about, because they'd been said the message discipline was absolutely fantastic, analogue to digital, sickness to prevention, and care closer to home. So there we go. How does the government kind of keep an eye on delivering those whilst also dealing with the urgent, the short term, the difficulties that you hear about on the doorstep?
Do you want me to take it first, Sarah?
Why don't you?
Okay, thank you. No, I mean, I think really interesting points from Rachel about the sort of public expectations about how quickly change needs to happen. But I was also struck by, Una, your challenge, what is the model of change? And I think, the government's been really clear, like no major reorganisation, so we have integrated care systems. I think it is about being really clear about accountability, and I think there's a lot of muddle at the moment about what their role is. I think you're right about the, Siva, you were saying about Tom Reardon's appointment, coming from the next door local authority where he was the chief executive at Leeds City Council, long background in local government. I think it's a really major appointment to bring that local authority knowledge right to the top of the Department of Health and Social Care, not least because social care dominates local authority budgets. So we must put as one of the really major things coming up is the local government settlement. That will make the biggest short-term difference to, and I've got a council who's sort of on the brink of bankruptcy, largely because of particularly children's social care costs and demand, but also adult social care. So that I think is fundamental, and I think that leads to the model of change, which is effectively, let's be really clear about the what, and I think the signals, the 3 simple shifts, it will obviously get further elaborated in the NHS plan, it will get further detailed in things like the operating framework, but we have been really, really clear already, signalling that shift, the long-term shift. And I think it will be about devolution. It will be about real clear accountability around, first of all, integrated care, but then neighbourhood, sort of taking it right down. So that place-based approach. I think that, those building blocks have been very clearly signalled, and I think that is the model of change. The question then comes, if we have given that very clear long-term signal and the short-term, settlement to local government, how quickly do they start to deliver? And I think that is the real challenge. And, I'm looking at Professor Nick Mays at the back there. We wrote a book about the last Labour set of reforms, and a lot of our conclusions were about the failure of implementation. And I think that's, when you sit in the Department of Health, as I did, working for Una, one of the issues that you've got to try and get ministers to understand is that, that there aren't levers that you can easily pull. So I do think that remains a challenge, is how, even if we do those things, does that then translate into fast delivery? But then that comes down to good local leadership.
Thank you. Siva.
Thanks. And I guess 2 things. One is, the government absolutely does have to set some of the conditions and can absolutely have a role to play. So digital passports, absolute clarity and changing the terms of the debate over something like information governance, is something that a government can do. But I think, all of us, I think, on this panel have worked in Whitehall at some point. And so that in Whitehall, you don't actually run anything. Someone like James runs something, runs a service. So I think partly if you want to see benefits in the short term, it's creating the conditions for people to get on and crack on with the job rather than thinking you from Whitehall are there to solve every problem. So I think absolutely set the conditions, but don't create this sense of inertia of people waiting for the plan before going on and doing things. And the second thing is working back, we were all probably thinking about Una's sister, really working back from all the national policy guff that I was talking about. We've got about 5 years before another election. What you want to do is for people to feel differently about the health and care service and have greater confidence. And I would feel differently about the health service if I get a choice over appointments happen when they're meant to, things just run smoothly. So I think what the government could partly do is create the conditions for a different feel of how we experience healthcare in this country.
Yeah, well, we talked a bit about the model of change. So here are some of the things that, in my idea, need to be in it. There's a lot in the sort of leadership literature at the moment about leading through complexity when there's lots of uncertainty and variability, and this applies to a lot of global businesses. So taking some of the sort of strands of how global business leaders think about managing change and applying them to the way the Department of Health and Social Care might work. One of the things is having a consistency of purpose, and I think new government, as far as health and the NHS is concerned, have sort of struck a strong chord there. We've still got, as we mentioned earlier, things to be filled in, particularly around social care. But getting a clear consistency of purpose and sticking to your narrative through thick and thin really does matter. So we don't want this sort of change of goals or phrases every couple of years just because people have got bored with the comms or whatever. The power lies in really sticking with the overall goal and purpose. A second thing is, it might be a bit of a controversial word, I don't know, subsidiarity. And what I mean by that is only do the things nationally that need to be done nationally. It's a deep frustration of mine working in government, and I can get it, the temptation. I don't know, Anna, if you would ever, I doubt you'd fall for this, but you fight so hard to get into government, and then you find yourself as a minister, and the temptation to dip into stuff that doesn't really need you because you can and because you're at the centre and people go along with it. I think we need self-discipline and refraining where it's not necessary, and we need purposeful action, picking up on Siva's point, where you can adjust the rules and the incentives and do it once at a national level that will help everybody. So we need smart intervention, not just intervention because you can. So really, I want to see more clarity about the relationship with the integrated care boards and the localities, more devolution and more willingness to accept different pace of change. And then the old challenge is going to come: what happens when a particular A&E or a particular service or building is being closed and the local people don't like it, but it's the right thing to do for the health and care system in that entire locality? That will be the test. Does that get escalated into parliamentary debates, into ministerial intervention, or do we trust that the assessment done on behalf of a whole population to be supported? I think that will be the big test. I'm not looking at you personally, Anna, on this.
Thankfully, I don't have a hospital in my constituency, so I
you're
won't.
probably very lucky.
Yeah.
And Rachel, how optimistic do you feel about this sort of short-term, longer-term dilemma and tension?
I mean, I suppose if I were going to be cynical, I would say that I've seen quite a lot of papers and strategies about shifting to long-term and prevention. But when the hospital's on fire, you fund the hospital. And when people are dying on the A&E floor, you put money into A&E. I mean, you guys tell me if you think that's about to change. I would be slightly surprised. I thought one of the things that was interesting from these responses, because it's kind of a signal of like how basic some of the changes are. It's like, yes, don't change your mind every year. That would be a really good start. Like, I can't believe we really have to say this. But we do. It is one of my frustrations, because I am a Conservative, that under the Conservatives, we ended up with a much more nationalised, more bureaucratic and more sclerotic NHS than in many ways we inherited. And some of the ways in which things were much more devolved under Blair seemed to me sensible to go back to. But that's not answering your question. My assumption is that given that the two things that drive anger at the NHS are, above anything else, the sense that A&E is falling over and GPs, that is where in the end the money will go.
Thank you. Right, we'll take some questions from the room. We'll take 3 at a time, and if you could just keep questions brief and introduce yourself first, that would be wonderful. Question in the middle here.
Hi, Richard Evans from the Motor Neurone Disease Association. We've seen pharmaceutical companies complaining that it's increasingly difficult to get drugs onto the NHS And I wonder if you think that's right, and do you think it's going to get worse or better over the next 5 years?
Thank you. Jacob at the front here.
Hello, I'm Jacob Lant from National Voices. My question is about yesterday's launch of this big conversation with the public, which I think is brilliant because it's not often we see things on that scale around public engagement in the NHS. But my fear is that that will be done and dusted when the 10-year plan is published, and actually, given the difficult decisions ahead, that conversation needs to continue and continue at that sort of scale for the next 5 years. Do you think that we'll maintain that ambition, or do you think it will just be like consultations of the past?
Thank you. And then front row here.
Morning, Lee Peart, Healthcare Management. What impact, if any, will the budget next week have on waiting lists?
Thank you. So a question about the budget, about the big conversation, and I think some of the trade-offs that maybe we need to be talking about, talking to the public about, and access. Who would like to go first? And don't feel you need to address all of the questions.
Well, can I pick up Richard's point about the pharmaceuticals? Because actually that's one very, very important thing that none of us mentioned, which is, I can't remember the current figure, but I know that more than 10% of NHS spend goes on medicines, and about half of that through GPs and the other half through hospitals. So it is a hugely important part of our NHS spend, and we actually spend, as a percentage of our health spend, less than a number of West European countries on pharmaceuticals. So I don't know if anybody's ever come up with a right figure for that. You know, should it be 10%, 15, 17%? But clearly, medicines and vaccines are a fundamentally important part of our ability to deliver a modern health service. And the other feature, which is such a powerful element in the growth argument, is the role of life sciences and the pharma industry and the fantastic universities and research base that we have. So I absolutely understand the pressure and expectation on the access to new medicines that people, particularly with life-threatening diseases or life-limiting diseases, have. A number of innovations have been made on this over the last 10 or 15 years, and we've yet to see what steps the new government is going to take to balance this pressure to bring new medicines in quickly on the one hand, and on the other to meet some of the extremely high development costs that are coming through with these medicines, particularly on rarer diseases. So I think it's a genuine conundrum, and whether or not the remit of NICE is going to be changed in all of this, I've seen some emerging debate about that because that remit has been steady for a very long time. So great question, and one that we'll definitely want to see how that develops.
Thank you, Rachel. Yeah, just quickly on that, I think, since I've been the gloomy one, one of the exciting things about this government is they seem genuinely pro-innovation. And I think they're going to try quite hard to push through digital innovation, but also medical innovation through the NHS. So it seems to me plausible, except there's no money. On the conversation with the public, I'm interested in others' views, but this seems to me an area where the CQC has been way behind other inspectorates in other areas, and in general the way in which the NHS has institutionalised public and patient separately. Engagement is way behind. So if we are rethinking what that looks like, that seems to me a real opportunity to do this, not in just a chuck in your ideas for how to do free parking for the NHS, which is great, but actually also how do you get those feedback loops happening? That seems to be a real opportunity. On waiting lists, the big thing I think we have to talk about a little bit more maybe is what is going to happen to the fiscal rules on capital investment, because that is the big unknown, which could dramatically change how investment in the NHS works over the next few years. And at a broad level, I think there's general agreement that we have underweighted towards capital investment and management versus frontline staff over the last few years, and reweighting that it is likely to have a big impact.
Siva.
Thanks, Sarah. So I'll try and do a rapid fire round on each of those. So Lee, on the budget, who knows what's going to be in it, but I'd say there were some specific manifesto commitments that are targeted to waiting lists, including extra funding for 40,000 more appointments a year. So you would expect to see something specifically tied to your manifesto commitments. And the government did say that they're going to recover all access standards by the end of the Parliament. The end of the Parliament will approach very rapidly. So again, will there be something? I'd assume there'd be something, even if it's not specifically tied to this is what we're going to do to improve mental health waiting times. You have to refloat the service, I think, if you're not going to junk that ambition. So that was the thing on manifesto commitments. How much difference will it make? I think, you know, unless there is some massive change to the fiscal environment, helpful but not game-changing is my best guess. Richard, on clinical, analog to digital includes a hell of a lot of material on life sciences. Just to echo what other people on the panel have said, whether you look at clinical trials or medtech innovation, I think this is a government that, again, is trying to return to this idea of health being a wealth creator for the economy, not just this anchor weighing down the economy. So I think they're making the right mood music, but I think more specifically around clinical trials, I can see what the plan is. I can't see yet what the innovation and life sciences strategy is beyond that. And Jacob, on the big conversation, I'm going to sound so naive. I think it is a game changer, because how can you have a conversation with the public where you're asking us, what do you think about the health service? What type of health service do you want to have? And then you say, well, great, we asked you in, God, what year is it? Yeah, I don't know what is going on with time. 2024. we asked you in 2024, and that was your chance for a generation to tell us what you think about the healthcare service. I mean, once you open this box of saying what's really important to you, as Rachel was saying, it's one of the most important things. Having a dialogue with the public about what do you think needs to happen. How do you then put that conversation back in a box? So I think whether they did it intentionally or not, they've probably started a national conversation that is going to be very difficult to end.
Anna.
Yeah, just a couple of things. I mean, obviously, I'm also not going to be preempting Rachel's budget next week. But what I would say is critical to, waiting lists and what we've said in our manifesto, is workforce, whether that's getting more mental health specialists. But also, it's been things like, sorting out industrial dispute. Because whilst we had a junior doctor strike, we were not going to be getting the waiting list down. So I think, regardless of the quantum in the budget, it's very clear that, that's the way that we're going to be delivering on our manifesto commitment around waiting lists. Isn't it fantastic that we have launched this huge conversation? So I think, the main thing now is just to encourage as many people as possible to participate. And I think if there is demand for it to continue, clearly it's a very important moment to be having it, so that the 10-year plan, which will be a 10-year plan, and those long-term ambitions are informed by what people want to see. But, every organisation within the NHS, this is where ongoing feedback. I was responsible once upon a time in the government civil service for the Friends and Family Test, which is very, binary sort of question. But really what you want is insight, co-design, clinicians walking in patients' shoes so they actually know what the experience of the patient is before they get in the clinical. So I would sort of say, isn't it great that government are opening up a conversation? But really that ongoing conversation should be happening everywhere, in every place, in every engagement. We're also very committed with the National Care Service that will also be a big conversation. So I think, more of it to come, most definitely. And just on drugs, I mean, great that what people have said about life sciences. From a constituency MP point of view, the issue is basic drug supply of existing drugs. Like, people are running out of chronic meds, ADHD medicine, HR replacement, Creon. There are massive supply issues, and we have community pharmacies who are falling over because they are not, like the wholesale price that they're paying, they're not getting enough for dispensing. So, we've got an issue about community pharmacy and medicine supply, which, from my point of view, is probably a more urgent one to solve in terms of constituents and what people are experiencing currently day to day, never mind the more sort of like innovative drugs that are coming down the pipeline, which are obviously also important.
Thank you all. Let's take another round of questions at the back in the middle.
Mays, London School of Hygiene and member of the Advisory Council of the King's Fund. I've got some advice and a question, or comment and a question. The advice to those involved in this whole process would be we've had quite a few 10-year plans, to do some reflection about what happened to the last one, because some of them are quite good on paper. And my question is related to that. What do we think we should do to assist each of the service delivery teams that we are going to be encouraging, requiring to innovate and change their service, to give them the headspace to do that? Because I think there's a great tendency when we put money back into the health service to talk about we must give it to the front line, and we've got to deliver more clinical outputs immediately. If I was running a clinical service and I wanted to change on the basis of a public discussion and ministerial imperatives and my own professional commitment, my experience is in many of these programs I've looked at, the lack of headspace, the lack of time to develop and implement change has been absolutely crippling. People are basically having to do two jobs at once under pressure, and I think that also relates to my comment about some of those previous plans. Which bits got implemented, which bits didn't, and why?
Thank you. Question, lady here.
Hi, Mimi Launder from HSJ. On the shift to devolution, I was wondering what that could or should mean for the relationships between local authorities and ICBs, given they're often very strained and there's a lot more power on the NHS side. Thanks.
Thank you, and then Maren.
Thank you. Maren Simpson from the Health Creation Alliance. Has mainly been a talk about, well, thank you, Una, initially for, firstly for talking about what model of change is required. And there's been a lot of talk about devolution and setting the conditions, even when we're talking about the big conversation. But what about devolution from the ground up? Is that a possibility? One of our new ambassadors that we've recently appointed talks about the need for a form of change that everyone can own, and that includes communities themselves as part of this. So health creation, as we form it, has been built through looking through the community lens. I think today, obviously with the 100 days of government, we've been looking through the policy lens today, but when you look through the community lens, it demands a more relational model of change. And I just wondered, how can we, the question at the end is, how can we refashion and grow the space between the ground up and the top down to kind of come to a different way of working that lasts longer and that works for everyone?
Thank you. Excellent questions. I think two really about the model of change. Actually, the King's Fund has done some work on previous plans, what's worked, what hasn't. And it's certainly the case, as was said in opening comments, the shifts this government is talking about are not really new shifts. Other governments, in a way there's been a crushing consensus in some of what we need to do. It's really hard to do it. So how do you go from fantastic plan to implementing the plan? Something about your model of change, relational, community, bottom up. And then interesting question about power and balances of NHS, different parts of the system, and often the predominance of NHS. Anna?
Shall I start this time? Okay, go the other way. So thanks very much, Nick. I really appreciate the sort of challenge of innovation that particularly frontline staff face when they've got a busy day job, to sort of add into everybody's day job a bit of innovation we know doesn't work from the innovation literature. So I think we're already seeing examples with our, I think we're calling them crack teams, which I'm not sure about the language, but anyway, these clinical hit squads who've experience of doing things well in one place, going to work with clinical teams elsewhere. And obviously under the last Labour government, we had quite a lot of these sort of clinical action teams who would take innovation. And I think you need dedicated innovation staff to take models that work and help to redesign care elsewhere, because putting it on everybody when they're already busy, we know doesn't work. And I suppose that comes to other models that we do know. So thanks, Maren, and hi. In terms of that community-led approach, I think this is a real strength of local authorities. They get community asset-based development, whatever you want to call it, but community development, about harnessing our very vibrant voluntary and community sector. Declaration of interest. I'm also a trustee of Helpforce, which is a charity that seeks to bring volunteering to health and care. We've got huge unharnessed potential of community within the health and care system. And, I think that there's a real hope, at least, that bringing together local authorities more closely with health partners, that there's a real opportunity to get that right. And I think in terms of public health in particular, that is the model and part of the ambition which were, hoped for when public health was put into local government. Sadly, with a lot of the budget cuts that have gone on, their power is perhaps somewhat diminished. But I think there are real opportunities, particularly in the public health, but also bringing local authorities and health partners together with the voluntary and community sector to really harness that sort of community approach to change. So hopefully we'll see more of that.
Someone ought to go back through those plans if they can bear it and have a look. One person who did something like this, Dr. Dolly Thays, has done an analysis for her recent doctoral dissertation on the obesity strategies published by the Department of Health over sort of 20 or 30 years. And it's an incredible piece of work, because what she was able to show was how frequently the same recommendation appeared every sort of 5 or 6 years, and how weak the implementation plans were in each of those strategies. And to actually have that sort of mirror held up to politicians, civil servants, policymakers, I thought was very, very powerful. So we do need to really be on the watch for this, that, you can have a fantastic document and it can say all the right things, but where is the grit in the delivery, not just the plan, but actually where the responsibility lies and who's got the power to make change. I'm very, very drawn to a more community asset-based model of change. I don't think we know nearly enough yet how to enable that. I noticed that the NHS Confederation have got an incredibly interesting list of recent examples of the voluntary sector working at community level to develop and improve people's health. And they've got about 30 or 40 pilot schemes that they've summarised on their website, which I think, to me, is the germ of really where we need to go. But tying that up with the role of the national politician and the government leadership, I think, is a big challenge.
Well, my quick follow-up to that was going to be, how much political courage does that take in reality to let go and give it time, have the patience to watch that deliver?
Well, I think this is where the government's majority and the members of parliament are going to be so crucial, because how health change in a health and care system is understood by Anna and her colleagues is going to be really critical, particularly where you happen to have a constituency with some infrastructure change, and how you all see that and portray that to the public, how you campaign or don't campaign around it, I think will be really revealing. And I don't know where your thoughts are on that yet, Anna.
No, I was just thinking about, Rachel, your sort of comment about, how impatient the public they won't necessarily. But I do think then there is a leadership role, as you say, for MPs like me to try and relay what is changing, to talk about, we made promises, we are delivering, this is what change looks like, but it takes time. And I guess only time will tell about, when we come to the next general election. I'm, obviously very confident in Wes and the team that, a lot of what we've promised will have been delivered. And it, and as we say, it's about the leadership out there in the NHS and social care. But yes, we as MPs have to show leadership in talking through the change that's coming, and pointing to signs of it, even if it's just green shoots at the beginning.
Thank you, Rachel.
Yeah, I guess sort of picking up on that, and it ties to the question about the 10-year plan, I think if, in my kind of 20-ish years around politics, if politicians make one consistent mistake, is that they always assume people are paying more attention than they are. And that's true in terms of political communication, but I think it is also true in terms of policy, that they overestimate how much nuance and subtlety and complexity they can drive. And actually saying, COVID is a good example of this. If, let's imagine that the only message that the last government had given consistently was, we made decisions during COVID that left us in an utter mess and it's going to take several years to get out of it. Would it avoid them losing the election? No. Would it have changed what people thought was going on in the health service? Potentially, if it was the only thing they said. And so I think that is true. And I also think it is true of these plans, which is you are never going to change that many things. You have to be very clear and very simple and consistent. You need to make sure the money and power aligns to it, which I'm not sure it always does. Siva.
Thanks. Yeah, I wanted to come back on Professor May's question before we do the devolution question. And two things. One, I'm not sure when the last time we actually had a plan was, because what you'd want is you'd want a strategy, you'd want a plan for how you're going to staff it, how much it's going to cost. And we haven't had all those probably the last time was the NHS plan back in the early noughties. Just as one example, I sort of fell in love with the 5-year forward view, if people remember that from 2015. Yeah, I could, as a patient and service user, look at it and see, that's how my care would be better. But it didn't have an associated workforce plan, it didn't have the funding behind it. So to a certain extent, let's learn the lessons of the past, but we might have to look quite a long time in the past. And the second thing, just on innovation, absolutely you need time to innovate. I know this is really back to the future, but something like the NHS Institute, where you have this body that can suck up innovation and push it back out to the service. So I think you also need to support people to learn. But the final thing is, why are you doing it? I mean, to be honest, national policy is a pretty crappy reason to innovate. If you're leading a service, have people heard the Don Berwick coffee grounds story? Yeah, a few nods. He was, I'll give you the short version. He was in an airline, went to use a bathroom. If you've ever been on a bathroom in an airline, you know what that's like. But he saw coffee grounds in a pot, and he asked the stewardess, why have you got coffee grounds in the pot? And the stewardess or the steward said, well, we've just realised that it takes some of the smell away. And he said, oh, is it policy for the airline? And she said, well, he said, no, we just did it. He said, but why? And he said, well, we saw a problem and tried to solve it. And it's that sort of spirit that isn't driven from national policy that we should try and flourish, not extinguish. But I think the one thing I keep coming back to is when you look at the evidence, the main way you can create time to innovate is by having enough people to deliver the service you want. And we are not there yet. And that's the conundrum that I think we haven't yet got to the root of.
Thank you. Very conscious of time. I've got a hard finish at 1:45. If I could ask a quick final question and then, oh sorry, do you want to?
I was just thinking about Marin and Mimi's questions and whether we wanted to do another.
Well,
okay.
Yeah, no, I know Rachel's got she's got a very
Sorry.
hard finish. So, I wanted to just ask a final question, broadening out. So we've had the chief exec of NHS England saying the NHS is only responsible for 20 to 30% of people's health, and to ask a question about sort of mission-led government. If we are to improve health and value health of the population, if we're to grapple with some of our social care border challenges, mission-led government is sort of being held up as a vehicle to really think about health in all policies, you know, from housing to communities, environment. I'd just be really interested to get the panel's reflection on the broader challenge to improve health, to reduce economic inactivity, and maybe in the interest of time, you might want to wrap in a final message for the new government. You know, we've had, or however you want to frame that, Anna, we've had 110 days. What's the one message you would like to give as they think about the next 100 and the years to come? Rachel.
Well, let me try and ally those two together, which is, I think, mission-based government could be very exciting if the Prime Minister and Chancellor is driving it, which they are not yet. But it still has to be selective. And the risk of the missions is they try and do everything and they rule nothing out. and linked to some of the questions, some things we've been discussing, they're going to have to choose a few things and drive them through consistently.
Una?
Yeah, well, mission-led government, I want to see the health mission broadened. I don't want it just to be NHS. I mean, there's no point trying to second or parallel run the mission board with the Department of Health. I mean, that and NHS England, that's just going to be duplicative. Anna will know this is a long-held passion of mine, health in all policies, and the problem across Whitehall has been that the health impact assessment has become a complete tick box exercise and not taken seriously. We need serious leadership for health in every government department, and I'd start with planning reform. If we don't get health really taken seriously in the planning reform, we're going to lose a big opportunity. So that would be my number one call. And the second one is in culture, media and sport. I mean, we are not talking yet at all about open spaces, about community facilities. The disaster of closing libraries is a horror. So we need health in all policies, but in a really meaningful, grounded way. And I hope with Clara Swinson, who's now in charge of all the mission boards, a former director of global health at the Department of Health, we've got some genuine influence on the civil service side around that.
Thank you. Siva, and then Anna, I'll give you the final word.
Thanks. Money isn't the only way to show you love somebody, but it is a very good sign. It helps. So one thing to think about is, could the health service give some of its money away? Give some of its money to communities, give some of its money to local authorities, and in doing so, recognise that it's not the only way it can improve the health of the nation.
Anna?
Yeah, so I think what's really clear is that the mission is about the health of the nation, and I think that's absolutely paramount, and I think it's fantastic that we are putting public health, social care and the NHS up there together as things that, you know, all have to be and are interdependent, that we can't sort of sort one area out without the others. And I think it also, as somebody who comes from a public health background, gives me hope that we do recognise that there are many different levers across government that are absolutely necessary, and there are interdependencies between policies in other areas. The other, though, I think, and this comes to, we know that Whitehall is siloed and it's very, very hard to do this. And so I think that the other place that we need to start and look at the health in all policies is if we devolve and at that local level, where I think it's much easier. I've seen it with the West Yorkshire Mayor in our area, where in Bradford District the council's working on a place base with the health service, so their footprints are aligned between place and council, more or less. And I think that's where the opportunities really come to tackle those wider determinants. And certainly our Minister for Public Health, Andrew Grin, is very ambitious about us being a marmot country. And I think we haven't talked much today, but about those health inequalities, which I see within my own constituency between the poorest part and the richest part of that area. And they are a mirror of those gaps in life expectancy and healthy life expectancy that we see across the country. So I think tackling those are key.
Thank you. We are out of time. It's been a really fantastic conversation. Please thank the panellists.
Thanks.